Degeneration Association. I'm the Communications Director for the, nonprofit. Today we are here thanks to Regeneron, Apellis, Sun Pharma, AbbVie, MacuHealth, and No Television, as well as people just like you. The Macular Degeneration Association is a 501c nonprofit. We are funded completely by donations, so if you find this information helpful and you would like to support us, we would greatly appreciate that. You can visit us at macularhope.org and make a donation there, or you can make a donation here in person if you so choose. We are going to first be hearing from Dr. Weber. Dr. Weber is a member of our medical board. She graduated from McGill University and furthered her education at Columbia University of Physicians and Surgeons. Dr. Weber completed her postdoctoral training in ophthalmology as a resident at the New York Eye and Ear Infirmary and pursued a fellowship in vitreoretinal disease and surgery at Shepard's Eye Institute, Mass Eye and Ear Infirmary, and Harvard University. Dr. Weber is certified by the American Board of Ophthalmology and is a member of the American Academy of Ophthalmology and the Association for Research in Vision and Ophthalmology and the American Society of Retinal Specialists. She currently practices with the Vitreoretinal Consultants of New York out of Shirley and Cormac. Dr. Weber is going to first be speaking to us about can diabetes affect your eyes? So, Dr. Weber, you have our attention.
Well, thank you for coming. I see a lot of familiar faces of some of my patients. I also want to thank the Macular Degeneration Association for inviting me. I think what they do is amazing because these lectures are given throughout our country. Not always by me, I do a few, but and I think that there's a real need for this in medicine because doctors are busy and a lot of times you have questions and diseases are confusing, drugs are confusing, and nobody has time to really sit and talk to you and help you understand what your options are and how you choose an option. So, you know, we really need something like this. And this organization was set up by Larry Hofheimer, who's not here. He used to come to many of these, but he lives in Florida. And he did this. He set this up as a retirement project. And can you imagine? And he also had to set up another organization for Parkinson's disease. So this was just something that he knew, he could see that there was a need for it, he had the ability to set this up, and he did. So it's been very successful. I also want to thank Regeneron and Apellis for providing me a few slides. And of course I want to thank Donna for coming and Dustin for coming and helping us make this program possible. So we're going to do two lectures today, one on diabetes and one on macular degeneration. These are two very big diseases that affect many, many people. And I just want to tell you about my financial disclosures. I am a researcher for Genentech, Opthea, Oculus, and Ocular. So when we think about diabetes, it's just a huge problem within the United States. Probably at least 11.7% of adults are diagnosed with diabetes and have some disability from this. And what's very interesting about this slide is you see that the numbers are increasing rapidly. And in 2010 we had about 7 million people, but it's expected that this is going to double by 2050. So we're not on top of this at all, and that's a huge problem. And this is not just something we see in the United States. We see this across the board. And globally, probably at least 800,000 people have diabetes, and several million are blind from this. So it's a huge, huge problem. When we talk about diabetes, we talk about type 1 and type 2. Type 1 is a diagnosis that's usually made earlier when you're a little bit younger. And it's usually diagnosed quickly because patients are very symptomatic. And this is really an autoimmune disease, and it makes up about 10% of all of diabetes. So what we do see is, of course, an elevated blood sugar. That's how we make the diagnosis of diabetes. And with this, when you're diagnosed as a type 1, we recommend getting an eye exam after 5 years of having the disease. It does take a while once you have diabetes to start to develop some of these problems. And like I said, usually this is diagnosed early on, so you don't have to get an exam right away, but usually about 5 years later. So, like I said, type 1 is an autoimmune disease where basically the pancreas stops making insulin. And this is rather detailed, but basically the beta cells within the pancreas stop functioning properly. There is a genetic predisposition to diabetes. We don't really understand it well. It's not something we check for, but we certainly know that it does run in families. Okay. So the thing about diabetes is it affects every organ in the body. So when my patients come and see me and I make the diagnosis of eye disease, I already know that they have other problems. They may have peripheral neuropathy. They may have the beginning of kidney disease. They may have sexual dysfunction. These are all things that happen with diabetes, and when the eyes are affected, every organ is affected because this disease affects small blood vessels. And so the eyes can be affected pretty early on because obviously there's lots of little blood vessels, but it also affects the larger blood vessels so we see our diabetics who get heart disease and so on and so forth. A really good way to figure out where you are with your diabetic management is to get hemoglobin A1C. And we always ask our patients, how is your hemoglobin A1C? Because it tells us how you've been doing over the last month or a couple of months. And usually the doctors will order this, your interns will order this maybe every 3 to 4 months to see where you're at. And this helps us put you in some sort of range so we know how to talk about this. So pre-diabetic in the United States is considered 5.7 to 6.4. And if you are diagnosed with as a pre-diabetic, this is your opportunity to get in charge of your health because you can reverse all this stuff. And so if you're diagnosed as a pre-diabetic, get on it. Work on your diet, work on your exercise, and try to not allow yourself to go beyond. Because we do know that once you've been diagnosed with pre-diabetic, most people will go on to diabetes. But you can prevent it. So you got to pay attention to this. What's interesting is a lot of my patients come in way higher than 6.5. I have patients come in and tell me they're 12, 13, really, really out of control. So let's go back to the eye. So we all know what we're talking about here. And again, what I notice with my patients is they really have no idea about the structures of the eye. And you need to know. So the cornea is the clear covering on the outside of the eye. And there's lots of diseases that affect the cornea, but we're not going to talk about those today. And then inside behind that, there's a space called the anterior chamber, which is between the cornea and the iris. The iris is the colored part of your eye. Behind the iris is your crystalline lens, and it's held by little threads that are called zonules. And this would be considered the front of the eye, and anything behind the lens is the back of the eye. We deal with the back of the eye. Ophthalmology is really subspecialized, and there's a doctor for each part of the eye. There's glaucoma doctors, there are neuro-ophthalmologists, there's pediatric doctors, but my area of specialty is just this back of the eye, and it keeps us very, very busy. There's lots of diseases going on back here. The jelly in the back of the eye is really collagen and water, so it's very much like Jell-O. That's what Jell-O is. And there's a lot of things that affect the vitreous as well. And then we have the retina, which is this lovely orange color. And a subdivision of the retina is called the macula. And the macula gives you your really, really good vision, the vision that you really like. Your reading vision, your driving vision. So we're always trying to talk about, saving the macula. The thing also is that a lot of people come in and if they've been diagnosed with any kind of macular disease, they assume it's macular degeneration, which is not necessarily true. Macular degeneration is a separate disease. There are many diseases that involve the macula. The fovea is a subdivision that gives you, of the macula, which gives you your absolute precise vision. And then the optic nerve takes all this information to the brain where it's decoded as vision. We have many ways of imaging, and if you've been to my office, you know some of these imaging techniques. We have the OptosMap, which is really an incredible technology because you don't even have to be dilated to get a really good picture, and it shows us a wide view of the retina. So not only can I diagnose macular disease, but I can see what's happening in the periphery. You can diagnose retinal tears. And it's funny because one of my friends who's an ophthalmologist, I was talking to her yesterday, and she's like, they don't always, general ophthalmologists don't always dilate. And she was saying how, oh my gosh, she had this, the patient thought that they had conjunctivitis, he had no symptoms of retinal detachment. She dilated him, and sure enough, he had a retinal detachment. So we can pick this up. Almost every office should have one of these. And, you know, unfortunately not everybody does, but a lot of the optometrists do. And that's super helpful to us because they pick up a lot of stuff and send it to us for repair. So what happens with diabetic retinopathy? So the high blood sugar levels cause damage to blood vessels, little blood vessels, and it makes them leaky. And the leaky blood vessels can cause different problems. Sometimes diabetic macular edema, which you may have heard about, sometimes proliferative diabetic retinopathy, which is a more advanced form of the disease. So we talk about non-proliferative, that's an earlier stage of the disease, and then we divide it into mild, moderate, and severe. And you know, if your doctor tells you about this and calls it, you'll hear us say moderate, non-proliferative. The chances of progression are high. But again, you can reverse this. So diabetes is one disease that you can reverse. So if you are in this mild or moderate and you don't need treatment yet, and you get on top of your hemoglobin A1C, and you exercise, and you do all these right things, and you get on top of your diet, you don't have to advance. But we know, in general, not everybody does that. So if you're moderate, there's a good chance you're going to advance. And if you're considered severe or very severe, most likely you're going to advance. But again, you can change it. But when we start to see this, what do? Well, we start treatment with severe and very severe, and we monitor these patients carefully, and they come in more often, of course. Well, how would you know if you have a diabetic eye disease? You know, you may not, which is why you got to get these exams, okay? Sometimes you can look around. Sometimes people have blurred vision, they'll see spots, they'll have distortion, they'll have drop in their acuity. Sometimes they don't. We can start treating when patients don't have any symptoms because it's not, their disease isn't involving the macula. So you have to get eye exams, and they have to be dilated exams, or like an OptoMap where we can see without dilation. So these are some of the things you might look for. And there can be other things. There can be glare, there can be like blacking out of the central vision. So if you have funny symptoms, get in. You know, call up, I always say, call up the emergency, we'll get you in. So as I was saying, the little blood vessels get damaged. I don't think you have to know all this, but if you're interested, here it is. We lose little parasites, and the endothelial cells get damaged, and they start to leak. When the disease gets worse, we develop ischemia, which is lack of oxygen to the tissues, which causes new blood vessels to grow. New blood vessel growth is a huge problem, and we have to reverse that because otherwise you'll start to have all sorts of problems, which would include vitreous hemorrhage, where there's blood in the eye, and the vision goes down fast, and even retinal detachment. You can get retinal detachment from diabetic eye disease. So again, we talk about the DME, diabetic macular edema, because it's really quite common, and that affects this part of the eye, a very small part of the eye, but the part of the eye that's most important for good vision. And so what happens with DME? We get this leakage, and leakage in the retina is considered thickening. So we get these OCTs, which is like a cut, like a cake cut through the retina. So this is the retina, and these little bubbles represent edema. And edema will cause distortion of the vision and a drop in vision. But we can also go on to hemorrhage, like you see here, where everything is obscured because blood is bleeding into the vitreous. And that, of course, is a huge problem. We see all sorts of interesting things when we do these pictures. We see these funny distortions of the blood vessels. We see intraretinal hemorrhages. And if you come to my office, you'll see, we have the pictures right up, so you'll see us looking at all this and dictating all this different stuff. Hard exudate, which is protein leaking from these abnormal blood vessels. Abnormal hemorrhage and thickening and fibrosis, all these different things we're looking for. So here again is an OCT. Probably if you come to my office, you get an OCT every time. And here is a patient with macular edema and several layers of thickening with edema within the fovea, the center of the macula. This is a beautiful picture that my photographer Jim over here took. I think it's beautiful. Which shows the microangiopathy. So the other thing that happens is these blood vessels get damaged and they get outpouchings, little micro aneurysms. You may have heard of aneurysms in the heart and stuff like that. Those are giant aneurysms. But these are little baby microaneurysms, and they show up beautifully on the, this is a fluorescein angiogram. With a fluorescein, we inject a dye in the antecubital space, which quickly travels to the eye, and it looks white when we take the picture. And it tells us a lot about abnormal vasculature, abnormal leakage, and it gives me another very pretty way of figuring out what's going on in the retina, in addition to the OCT. You don't really have to know this, but I just wanted to put this in because you may hear your doctor talking about this. Things start out kind of simple, maybe a few little hemorrhages, but then as things progress, we see more and more damage to the eye, more hard exudates, more abnormal blood vessels, and then eventually we start to see this hemorrhage and leakage, which is very severe disease. So this is, if you did nothing, this would be the progression. And believe it or not, we have patients come in here, not here, and they just, I don't know, for whatever reason, maybe it's insurance, whatever, many different reasons, they come in very late in the disease process. And the thing about medicine is you have to be proactive with every aspect of your medical care. Whether it's your eyes or your bones or whatever it is, you have to, early diagnosis is the key to living a long, healthy life. And so it's very important to stay on top of the recommended screening that your doctor may tell you about. And here again we see, progression of the disease to hemorrhage. So risk factors, we already kind of talked about some of this. The longer you've had diabetes, the more likely it is that you're going to have problems. Hemoglobin A1C gives us a very good indication. And this number is always very interesting to me. So if you have a 1% increase, so if you go from the hemoglobin of 6 and A1C to 7, there is a 50% increase in the risk of developing diabetic macular edema. That's huge. So these patients who come in to me and they're 11 and 12, they're going to have macular edema, right? It's 100%. So, you really have to get on top of this and get it down and get it way down, because even a little bit of elevation, you can see, just throws you way into the category of advanced disease. There are other things. I always tell my diabetics that, you have to be on top of. They always, what can I do? Blood sugar, you got to watch your blood sugar. But you also, anything can throw your eyes off. So if your blood pressure is too high, if your cholesterol is too high, if you have cancer anywhere in your body, infection anywhere in the body, there will be progression of the diabetic eye disease. So you have to be on top of everything, not just your eyes. And again, it's very interesting. Inflammation plays a huge role. A little inflammation is good; it helps with healing. But a lot of inflammation it causes disease. So we're always talking about decreasing inflammation and keeping inflammation at bay, because inflammation leads to damage of the blood vessels. As you can see, it's a vascular disease and leakage. So one of the things that we realize is that when we have diabetic eye disease, there's a release of a protein called VEGF, vascular endothelial growth factor. And you need a little bit of vascular endothelial growth factor. Like everything, there's always a reason why our body creates these proteins, and this protein helps us with wound healing and things like that. So you need a little bit, but in these diabetic eyes, there's an overabundance. It's just pouring into the vitreous. And this protein, this abnormal protein, causes leakage of the blood vessels. And we see it in many of the diseases. There are other factors too, but VEGF is one of the major ones. And as I said, you need a little bit for blood, blood vessel repair, prevention, bone growth, wound healing. But these eyes are, have way too much. So what we have developed is an antibody to kind of soak this up and reduce the amount of VEGF within the eye. And this will slow down the disease process, and actually we can see a reversal of the disease process. As many of you know, these are given as an injection in the eye, which sounds pretty horrible, but it's actually pretty well tolerated. And we have many. A little giggling over there. Oops, let me go back. So the first drug we took was Avastin, and it's interesting because there was a very brave ophthalmologist who realized that Avastin that we use for treating cancer, and you get a big bag of it and you put it in an IV, could actually help the eye. So he took an itty bitty bitty the same Avastin and stuck it in the eye. And there was a remarkable recovery. He started this whole thing. And so pretty soon all the ophthalmologists were compounding this drug and giving it. And then, of course, the drug companies were like, let's make a special one for the eye. And so they started making Eylea, Lucentis, and these are very expensive, way more expensive than a little compounded Avastin. But there's very good control, and and the manufacturing is very, very good and all this stuff. So they were designed specifically for the eye. So the next one was Lucentis and Eylea. Then recently, Eylea HD came out, which is high dose. And what it is 4 times the dose of a regular Eylea. So it's super, super high dose, given in about the same volume. And that has been helpful too. Particularly, the idea was to really dry the retina, as well as maybe increase the interval between injections. Because when you get Avastin, many times you need like an injection every 5 weeks or so. With Eylea, it's as you can see from the commercial, some people make it 4 months. About 40% of patients will make it 4 months between injections. So the next generation of drugs that are better. As we go down the list, these are better. And then we also have some generics to reduce costs, similarly, which we use in my office. Bioviz, which I don't use too much of that, but it's pretty similar to Simile. And Vabysmo is another one of our newer drugs, which you'll see the commercials on TV. Vabysmo is also a drug we can probably extend most people out, so they don't need injections as frequently. But we have other treatment too. We've had laser forever. And laser's very good, We use focal where we treat the microaneurysms. I fire right on the microaneurysms. We do this right in the office. And then we have PRP where we put a lot of laser around the periphery to destroy some peripheral retina so that these ischemic guys can focus most of the blood in the macula to maintain as much good vision. We also use steroids. Steroids are effective in decreasing inflammation. There's a few. Triessence is one that we inject sometimes. Ozurdex is like a little stick, and that's pretty good, and that lasts usually maybe a month and a half to 2 months. And then Iluvien, which actually lasts about 2 years. So we have interesting steroids we can use. And then, of course, we have surgery for the more advanced disease where we have hemorrhage and abnormal fibrotic tissues and cicatricial tissue. And the surgery is extremely effective too. But you don't want to get to surgery, Let's see, closer. Oh, okay. Okay, yeah, so as I said, these are the newer FDA-approved drugs. Yeah, so this is how we do the injection. And like I said, we pretty well tolerated. We do this right in the office. We numb up the eye. We're not just, an itty bitty bitty needle in an itty bitty bitty drop of medicine, and we put it right behind the lens. And it's a very safe place because it's before the retina starts. And we don't have to inject it right in each of these abnormal blood vessels. We just have to get it into the vitreous, and then it will start to reduce that VEGF and calm it's like a calming thing. So it calms everything down. So we do this all day long, and it's pretty well tolerated. And this just gives you kind of an idea of what we can see. So here's an eye where we see diabetic changes, the intraretinal hemorrhages, and these kind of blue spots and everything. And this is a patient who got Eylea, which is a very good drug I use a lot. and you can see how the disease just calms down, like starts to disappear. It's really very interesting. And here's another patient. So this is a patient with edema. You can see how, we also get this like topographical map, and it shows us, you know, white is really thick, red is a little less thick, but we really want it to be like green in the middle, like this picture. So we quickly take a look to see how the edema is doing, and here you see these big bubbles of edema, and then we see this resolution. And of course, this patient will improve their vision quite a bit. And sometimes these drugs can have an effect in a day, like a couple days. They can improve the vision very quickly. Yeah, and as I said, we do laser. We do it right in the office, and it's pretty easy. We just put you in front of the slit lamp, the lens on your eye, and that can also be a nice way. There are some patients who absolutely refuse injections, and then we push more towards laser. So we have options. You know, you can always talk to your doctor and say, what are my options? What do I need to do? Oh yeah, this is the Ozurdex. I thought this would be interesting to show you. So it's a little pellet. We take a little, we get a little injector, and we inject it, and this little pellet kind of floats around like a little satellite, and slowly releases drug. And then the little skin that it's in will slowly break down. So it's interesting technology. Illuvian is also like in this little pellet-like form. This is the long-acting, and it can last for 2 years, even longer. But the little cartridge doesn't dissolve. So anyone who's had one of these, I think, is seized. Sometimes it floats around the eye, or sometimes it's caught in the periphery, but it doesn't go away. No, you don't have to take it out. You can just leave it. It would be hard to take it out. Yeah. So in proliferative diabetic retinopathy, more advanced stage, we see abnormal blood vessels. They bleed, they ooze, and they cause all sorts of problems. Many patients get lost to follow-up for many reasons. Some of the reasons are insurance. Some of the reasons are they're working. They tend to be younger diabetics, and you know they have lots of problems, lots of doctor's appointments, and it's just hard for them. And when they get lost to follow-up, they can come back. I had one patient who was supposed to have surgery. She didn't get clearance. She came back a year later. And, you know, and then we have all sorts of problems, you know, blood, retinal detachment, and then the problem really escalates and the prognosis goes down. But we can fix many with surgery. And this is this patient after treatment and surgery, and you can see that there was a huge improvement. So how do we do the surgery? The surgery is really interesting because I'm sitting when the patient's head is like here, and I have a scope that I'm looking through that goes into the eye, and I'm using my 2 hands, and I'm using my 2 feet. My feet control, one foot controls the microscope, and the other one controls my vitrectomy equipment, which allows me to cut and aspirate and put laser in, all these different things. So it's like a very fine, very delicate little kind of surgery like this. But very, very beautiful and very elegant, and we have many little tools that we can use to make the surgery successful. And one thing I like about treating these diabetic patients is we can really stabilize these eyes, you know, and if we get the eyes under control, we can stop treatment and they'll stay stable for years, like for the rest of their lives. We have patients who just come in now once a year, haven't treated in years, and they do well. So there's an end point, like where you'll get stable, we'll get you stable, and then I'll just watch you. Which is not really true of macular degeneration or many other of the eye diseases that I treat. So I do like to treat diabetics for that reason. So frequently asked questions. Let's see, I think it's clear over here. If I require high doses of insulin, will this hurt my eyes? What do you think? Any takers? Yeah. If I require high doses of insulin, will this hurt my eyes? Well, actually, no. We want you to be treated to the maximum so that the blood sugar comes down. So if it takes a lot to get your blood sugar down, so be it. Take it. The next question is, if my vision seems perfect, should I have knives in? Yes, of course, yes. So if you're type 1, 5 years after you get diagnosed, type 2, as soon as you're diagnosed, because our type 2s walk around for years before they're diagnosed because the symptoms are are more vague. And so our type 2s need to get to the eye doctor right away. Question number 3. How long will it take for my diabetic macular edema to be controlled? Yes. Let's see. Oh yeah, my point here is that a lot of my patients come in and say, well, my hemoglobin A1C has been controlled. Why is my eye disease getting worse? But it takes a long time to get the eye disease, and it takes a long time for us to get it better. So a lot of times you have to be controlled for 3 years before we start to really see control, where we can start to back off on treatment. So that's a long time. So again, think about your hemoglobin A1C. If you're pre-diabetic, get on it. If you're in the range of diabetes, get on it. Because it just makes everything worse the longer you've had it and the higher your hemoglobin A1C is. So again, the people who work with me know that I'm talking about this all day long. One of the best things you can do for yourself is to get a continuous glucose monitor, which we call a CGM. And it's really great. The technology is great. You stick it on, and you get readouts on your phone. There's a couple different technologies. But this is a real, everybody's different, and what makes your blood sugar go up may be different than what the other person does. And when you have this continuous glucose monitor, and you eat a bowl of rice, you can go, oh, I can't eat rice. And it really tells you what you can eat, what you can get away with, and where you're going wrong. And really, this is something that probably everybody should use, maybe not every day of their life, maybe for 3 or 4 weeks, so you get a feel for what you're eating and how it's affecting your body, and and so you can start to control your diet better. And I think they're fantastic, and everyone who gets one does better. Everyone has lowering of their blood sugar. Everyone has an improvement of their hemoglobin A1C because they see. They drink some Coke and they look and they're like, ooh, okay, no more Coke. So it's a great way to get you to control your eating and push you in the direction of foods that help you versus foods that hurt you, okay? And in general, what we want to do, and everybody's a little different, but you gotta keep away from processed food as much as possible, and especially our super processed foods. Keep away from things that are sealed up in a plastic bag in the middle aisles of the grocery store, and stay on the far ends. And I always tell my patients, Long Island is a great place to get tons of good fruits and vegetables, fresh vegetables from the farms. And summer's a great time to really work on your diet. Get out, walk the beaches, and eat good food. We also have insulin pumps. Insulin pumps are really great too. Again, we have technology that really helps people understand and control and get them on the right insulin level at all times. So this is good for some people. There's also a low vision pen, insulin pen, for my patients who have a problem reading it and not know exactly how to give themselves the insulin. There is a low vision one, which is really very helpful. I like to talk about the GLP-1s because, everybody's talking about that these days. And there's quite a few of them. Probably the most famous, the one that's on TV the most is Ozempic. And I think for many, many people, this is fabulous. Probably one of the best things that's happened in medicine in a long time. So the trick is, of course, this is only for type 2s, okay? And this does not give you an excuse to sit on your couch and eat potato chips, okay? No. But it can, motivate you. because these GLP-1s are being researched for a lot of diseases, because it seems like it sharpens the brain, it makes you feel better, and of course it helps with maintaining a lower blood glucose. And it does that in a couple ways. Number one, it decreases insulin resistance, and number two, it slows gastric emptying, so you're not feeling hungry and grabbing food all the time. So for many people, it's been amazingly effective in lowering weight and improving their diabetic management. But there are side effects, and I think we see the side effects in the higher doses. And now doctors are talking about microdosing. So always start with a very, very low dose and see if you can change, work with this, change your lifestyle so that you can, achieve the benefits you want without side effects. The side effects usually are gastric distress. The other thing that's really important is if you are going on a GLP-1, make sure you get an eye exam, because it's very well known that it can progress eye disease. And I think it's such a shock to the body to suddenly have these lower, these lower sugar levels that, it kind of throws the whole body off a little bit. So, you need an eye exam. My patients with really bad eye disease, I tell them, don't go on the GLP-1s until we get you under better control and we monitor you to make sure you're not having this sudden blast of eye disease. So that's really, really important. Let's see. So, we always for better treatments. Obviously, getting injections every 5 weeks is not the answer, right? And so, actually, in my office, there's a few things. These are all studies. Resolute is an oral treatment, which would be really great, obviously, instead of getting an injection. What we're doing in my office is the Diamond study, and this is a topical eye drop. So this is really good for DME. And it's phase 3. Oculus is a drug company that's doing this. And this could be an answer for some patients. So we are enrolling now. So if you're interested in being screened for this, you can come to my office and we can screen you. The benefit of doing studies, I think there are multitudes, but first of all, the drug company pays for everything, and often they pay for transportation, and they often give you a little stipend as well. And of course, you get treatment before anybody else can get treatment. The downside is that we always have a control arm where you're getting either standard of care so that we can compare how this drug works versus what we presently have. And if it's not better, we stop the treatment. We stop the study. So there are a lot of benefits. You get great care, lots of pictures, and people studying you besides me. So everything goes to a reading center. Jim sends everything out to reading centers. It's super well controlled. We have monitors in the office. Everything we do is monitored by bigger organizations. So our visual acuity testing is perfect. The way we shoot pictures is perfect. And you have lots of people watching what I'm doing, which is also very nice. It's not just me. So in summary, what I hope you picked out of this lecture is an eye exam. Very simple. If you have diabetic eye disease, you will not go blind unless you don't come and see your retina specialist. We have many successful methods of treatment so that if something doesn't suit you, talk to your doctor, maybe put you on something you like better. The key to all of this is controlling your blood sugar. It's not a primary eye disease, it's all about your blood sugar. Systemic disease. Better control means less treatment and get a CGM. And I think that's it. Okay, so now we're moving on to macular degeneration, and this is a very, very common disease, so you are not alone. And the basic risk factors include an age over 50, lighter eyes. We tend to see it more in patients with light eyes. We don't see it as often in our African American population. Smoking. Smoking causes this disease. You have to quit smoking if you're a smoker. And I say this all day long and nobody ever quits. Oh, there we go. The prevalence of this disease is huge. Probably 11 million people in total. Neovascular AMD is probably 1 million, and geographic atrophy is 5 million. I'm going to talk about each of these diseases more specifically. So everything starts out as dry. And we diagnose dry with these tiny little grooves that we see deep in the retina. Some people will progress, and about, I would say, maybe 30% will kind of stay at the drusen level, not really bother too much throughout their life. But I would say 70% will advance to progress to an advanced stage. And what I mean by advanced stage is about 20% will go from dry to wet, which means abnormal blood vessels are growing, and that's when we start treating with injections. And I would say another 50% will go on from dry to an advanced form of dry called geographic atrophy, which you hear about on TV because we finally have drugs to treat this. So the chances of advancing or progressing to a more advanced stage, which would be either neovascular AMD, the wet form, or GA, the geographic atrophy, is, I would estimate to be 70%. Not good. So when we talk about macular degeneration, as I kind of just already said this, so I'll kind of run through these pretty fast. Yeah, so this is what I was talking about. And again, we reviewed the eye. Does anyone want me to review the eye again? Does everybody get the eye? So as I said, the macula is really important. This disease involves the macula. Your peripheral retina is important too for, peripheral vision, so you can drive and see everything out here. But your fine acuity comes from a very small area of the eye, which is only about 1.5 millimeters inside. That's interesting. This is advancing. Okay. Why is it advancing? Oh. Okay. So again, we make the diagnosis when we see these little yellow spots deep in the retina. And what they represent is poor metabolism of the photoreceptors. You're supposed to, your eye is constantly turning over these photoreceptors, and you're supposed to clear it out, but sometimes in this disease, they don't get cleared, and so they just end up as these deposits, and that's what is kind of the hallmark of this disease. OCT, as I said, we do these OCTs all the time. It's a great way for us to follow all the different parts of the retina, and it helps us figure out how we're doing with the treatment, and if you need treatment. So you'll see me looking at these, thinking about it, and then deciding, are you better, are you worse, are we getting anywhere, do we need to switch drugs, do we need to treat more frequently, or can we hold off and not treat at all? So these are the things I'm looking at. This is amazing technology because we capture these pictures in seconds. It doesn't hurt you, it's just light, and what we see is so exact, and the technology gets better and better, where we're really looking at like individual cellular layers, and we can really learn so much in just a little bit. And we do this right in the office. I have great photographers, and we get the image right away, and so there's no developing, no nothing. You just get the images and you start analyzing right away. And the OCT shows us this kind of interesting cross-section, and these little bumps are the drusen. Now this eye is okay. There's a nice foveal depression. This patient doesn't need any kind of injections, but what needs to be followed. The other thing that we talk about is getting a fluorescein angiogram. We don't do that every time. Maybe, depending on what your disease is, we maybe do it once a year or so. But here we inject the dye, and then we get these beautiful pictures that give us kind of a larger, it's like a plane flying over the retina, and it shows us abnormalities of the blood vessels and what's leaking and what's not leaking. Okay, geographic atrophy, also called GA, is when we actually get thinning, where we lose, and it's not edema, but it's the opposite. We get thinning of the cellular layers, which gives us this funny section where it almost looks like a cookie cutter has been taken out of the retina. So what do we do with these dry patients? I do A&B genetic testing, and everybody does this, but I think it's very valuable because it tells me three things. It tells me how likely it is that you're going to progress, which vitamin therapy you should be on, and how genetic it is, how likely it is that you're going to pass this on to your family. And then based on that, we decide on the vitamin treatment. We know that general errors, like preservation and Ocuvite, can actually occur at about 15% of people. And then there's another group of people that doesn't help or doesn't hurt, so you're just basically throwing your money out the window, and these drugs and these pills are expensive. So we want to know that. So the culprit really is the zinc. Some people zinc helps them, some people it hurts them. And so we need to know, so sometimes we'll use some of these common brands without zinc. Like Visivite has one without zinc. MacuHealth is also really good because they have just lutein and this zeaxanthin, and so this is really safe for everybody. And so if you can't get the genetic testing, a safe option would be MacuHealth. And they also have more advanced forms of MacuHealth with different things in it, so you have to kind of look. So we really believe in home monitoring for if we see that you're going to advance based on your genetic testing, then we start talking about home monitoring. The first one we used was 4C Home because that was the first one that was available, and it's very good. Some people don't like it because it's a big instrument and you have to test yourself and you have to take this instrument around with you. And recently, a new company started called Ramoni. And this is a little easier because it's on your phone or your computer, and it does really nice testing, and it's very easy to use. But if you don't want to do either of those, then we have the Amsler Grid, which is pretty old technology, but it's basically like a piece of grid paper. Ramoni Health is good because your insurance will pay for it, so that's a benefit. So 4C Home, I'll show you how this works. This was approved quite a while ago, and we have a lot of information on it. When it notes that you're deviating from your baseline, it actually sends me an email saying, hey, get this patient in. We've observed the change. And we know that this picks up change before you will. So it's very important to do testing. And this is the device that you look in. You get this at your home. You do this little testing, and it will calculate all this, and then basically send me a report and say, hey, we're in trouble. Get this patient in. And again, it's been well studied, and we know that if you do this testing, we'll pick up disease earlier, and it's always about catching disease early, always. So why do we want to catch it early? Well, number one, we finally have a drug to treat the geographic atrophy, and this is called Syfovre, and the generic name is Pegcetacin, and it's the first treatment to get FDA approval. And we have quite a bit of information on it. So this targets complement because complement is overactive in these patients. And it works by blocking complement in these patients. But we do have to watch these patients because it is possible to get inflammation from, because it's biologic. So some people will have an allergic reaction to it, and some people will have advancement to the left form from this. A very small percentage, but you do have to be watched. The data is really good. It shows that if you get monthly injections, we're going to reduce the progression of this disease process by 35%. Which is pretty good. It doesn't make the eyes better, so we have to start treating earlier. It doesn't prevent progression, but it slows progression down. We will have better drugs down the road. This is not the greatest drug, but it's what we have.
What percentage of patients that it actually slows it down in? Is that the lowest percent?
No, not at all. So it slows it down in 42%.
What was the question, Susan? the answer is?
Side effect risk is very, very low. And we usually pick up side effects after the first injection. Very, very low. It would, like, 1 in 10,000?
Oh, 1 in 10,000 get wet, like if you burn wet.
Oh, no, wet, so I'm talking about infection.
I'm not actually, I'm talking about side effects. Right, the side effects should be wet.
Yeah, that's a good question.
Yeah, so the number of patients that get neovascularization is about 5%. Mm-hmm. Mm-hmm.
What about small red?
Very low. 1 in 10,000.
Could you repeat the question before we get to the answer?
Yes, so the question was, what are the side effects? Side effects versus benefit, basically. So the infection, very low. Maybe, I said 1 in 10,000. Retinal detachment, very low. Maybe 1 in 1,000. Recurrence of neovascularization or presentation of neovascularization, higher, about 5%. So going from dry to wet, about 5% chance. I've seen it. I mean, it happens. We haven't had any infection. We haven't had any inflammation associated with the drug. But we watch for it. So you should go on the drug, because if you don't go on the drug, you're going to lose vision faster. So this is, on average, this is how much it slows down the progression of the disease process. So how long, so you're still on a bad road, but instead of like crashing tomorrow, you may crash in 10 years. So, and then we'll have a better drug. So this is like the in-between stop, lots of research is going on, and we'll have better drugs. But this is, yes?
My question, at what point in the diagnosis do they recommend treatment by the drug?
So, it's a very personal question for the patient. I offer it to pretty much anyone where I see advancement of the GA. And she's like, how do you know when you're supposed to start the drug? So we're not preventing the disease, we're just slowing it down. What does that mean? Well, this is how the risk of developing blindness with this drug. So you can see that if you take the drug, there's a much greater chance that you're going to prevent blindness or severe visual impairment. So we're slowing down a very bad outcome, okay? So we don't want patients to lose vision. So we get a big risk reduction of losing vision and going on to blindness. So again, we have a lot of numbers here, but what I can tell you is everybody's like, well, how much information do you have? But we have a lot of information on this drug. So here it says, and this is, from our studies, there's 1 in 10,000 chance of a retinal vasculitis. So very, very low. In other words, that you would respond to the medication like as an allergy. We've had at least 250,000 that have been tested, that have been in trials. And we know that there's a 42% reduction in growth of the lesion at 3 years, if you're getting injections for 3 years. So it's effective. Is it the best drug ever? No, but it's the best drug we have now. So in summary, there's increasing efficacy over time. The more you use this, the more you have a reduction in growth of the lesion. It does reduce by about 42% at 3 years compared to controls. So you'll do 42% better than the guy that doesn't get it. Pretty good. We do have another drug called Izervay. This got, and it's very similar. The results are about the same. And this got approved after cyfloborate. I do use this drug. I like this drug. It also does the same thing. It slows the progression of the disease process. The more you use it, the more frequently you use it, the better are the results. Anyways, so that's our drug. But what happens? Well, as I said before, dry can go on to more advanced forms. But somehow this is on, I don't know if you can change it from auto to, I just, yeah, so it's just going really fast. So, okay. So as I said, some of these patients, about 20% will go from dry to wet. And in wet, we have, what wet means, which is kind of a misnomer, is that abnormal blood vessels are growing and they're bleeding and they're oozing. And so we use all those treatments that we had talked about earlier. Now, how do you know if you have wet? Well, you have distortion. And at first it's not too terrible, but if these eyes are not treated or they advance, it gets pretty bad, and it's very central. So you can imagine going through life with this kind of problem. It would be not good. So that's why we want to get on this. And here is just an illustration. So we have the retina here, and we have a break in the deeper layers, which cause the very vascular layer that it should be sealed off to start growing into this subretinal space, and then ultimately into the retina. So that's the neovascularization part of it. Okay, so these are facts that I kind of went through. So what do we end up with? Well, we have, like, a normal eye would look like this. Is the optic nerve, this is the macula, this is the peripheral retina. And here you see this subretinal hemorrhage, this bleeding that can occur. And of course, this is just terrible for your vision. But these drugs work, and they improve. So here again, we see subretinal hemorrhage, we see drusen, and we see fluid in the space between the retina and the subretinal area. And again, this fluid is what's distorting and what we need to clear. And again, we go down our list of drugs for neovascularization. We've kind of talked about this. We have Avastin, we have Lucentis, Eylea, HD, similarly BioViz, and Vabysmo. So we have lots of treatment options. Unfortunately, these are all injections into the eye. We don't have anything else yet. but patients do well with this. Minimal infection. We always tell our patients to be super clean right after the injection. But most patients do well. And here is what we kind of see. So here's Eylea is one of the drugs we love to use. And here you see all this thickening. And here what happens is it just changes. It just goes away. And the vision returns. So they're super effective, and they've made a huge difference in the way we manage this disease process. Again, it's an injection in the eye. This happens to be Lucentis, which we also use. Just inject it right into the vitreous. It's pretty easy, and it soaks up the VEGF, and it causes regression of the disease process. Eylea HD is approved for this diagnosis as well. It's 4 times the dose of regular Eylea. It traps and blocks VEGF. And the goal here again is to dry everything up and to get a longer time in between injections. And we know that some patients go a really long time. There's a couple ways that doctors will treat this. One is treat and observe, and if you come back and it's active, we treat again. Or sometimes we do treat and extend. So we get you quiet and say, you did really well with 6 weeks. Let's see how you do with 7 weeks. And we slowly increase the time interval till we kind of reach a maximum. Or sometimes we realize, this patient can go 3 or 4 months. Maybe they don't need injections at all. We can actually stop the injections. And again, we talk to the patients about this, and they help us decide whether we're going to treat as needed. Patients who hate injections but don't mind coming in get treated as needed. We have to follow them more carefully. Patients who don't want to come in so often, we do the treat and extend. I'm not going to talk too much about low vision. Most of the low vision stuff doesn't happen in my office, but there are optometrists, and we can give you names of optometrists who specialize in low vision. There's lots of technology out there to help you, and you just have to be willing to accept technology. You'll never be perfect. You'll never get back to where you want. And I think it's like, oh, I can't read the newspaper. Well, newspapers are hard to read, you know. So instead of reading the newspaper, put it on your iPad and blow it up and change the font and change the lighting, but you have to be willing to incorporate technology. But you can get a low vision newspaper. New York Times makes one if you really, some people just love to read a newspaper. We have a lot of different low vision devices, like the loops, the magnifiers, and the optometrist can really help you with this, but you have to go to a low vision optometrist if you're in that range, which is usually 20/60 or less. Lots of electronic devices, lots of devices that will read to you, watches that will announce the time, so lots and lots of technology out there that make life a lot easier if you have low vision. Okay. We have a company right here on Long Island, Science for Vision, and they provide lots of interesting low vision aids. And here's a few of the things we can print this out for you if you want to try to locate some of these low vision aids. So obviously we need better treatments. Our goal is always to do treatments. We better have better treatment. We do a lot of research at my place. What you want to do is, always make sure you're enrolled in a research project that's like a phase 3 that is being monitored by the government and so on and so forth. You don't want to just go to something that you've heard about, sell transplants or something that's given in some office in Florida. No, you don't want to do that. We are doing this study now, and we are enrolling, so if you're interested, you can do this. You can come to my office. You have to have new disease, newly diagnosed wet disease. It's a phase 3 study, so we've already gathered quite a bit of information. Phase 3 is the study that goes before the FDA. So with phase 3 studies, we always do 2 sister studies, and this is a multi-center study across the world. It's actually, the whole world is involved. This company is Australian. And what we're hoping with this drug is that we'll get better results, save more vision, and have, get the patients under control with fewer injections. This is another study that we're just starting. Enrollment is open. And this is really interesting because it's an injection of a new drug, and it's a little pellet, and we're hoping that the way you get enrolled is half the people get Eylea regularly, the other half get 3 injections of Eylea, and then get this pellet injected. And we think this pellet will last 6 to 8 months, maybe even a year. So you would reduce your number of injections significantly. So if you have newly diagnosed disease and you want to go into the study, call us. Yeah. And Avicida is something that we're studying for geographic atrophy, and it's a new drug. It's also an injection, phase 2, so it's an earlier study. And again, my group, I'm not doing this study, but my group, BRC, does quite a few studies, and we can help you enroll in any of the studies that are being done through BRC on Long Island. So again, what are foods? People ask me, like, what can I do? What can I do, to help myself? No smoking. Smoking is out. We talked about the vitamin therapy, how we figured that out. There are foods that can be helpful. Dark green leafy vegetables are great because they're a natural source of antioxidants and zeaxanthin and lutein, all the stuff. So they're really good. Omega-3s that we see in fishes are very, very good, not just for the eyes, but for the whole neurologic system. Great for the brain. Great for slowing down Alzheimer's disease, preventing Alzheimer's disease. Very, very important. And red wine, if you want to drink, choose red wine. Not a big proponent of that, I don't think it makes a huge difference, and dark chocolate, So you can kind of have fun with this diet, it's not terrible. You can advance it. Okay, frequently asked questions. Can A and B be cured? Do I have a taker? No. Correct. Will I eventually go blind? Any takers? Yes. No. But you might need a lot of eye care. Can I keep the vision I have now? Yes, and in fact, we can improve vision. Not so much with GA, but certainly with subretinal neovascularization. Probably 80% of the patients get an improvement in their vision. So there's a good chance with treatment, the neovascular AMD, your vision will improve. So you can always call us. I don't know if I have time to do vein occlusion. If not, we can stop here. Okay. Go ahead. So I wanted to also talk a little bit about retinal vein occlusion. It's not as common as the other diseases, but some of the people in the audience might have this. Can I advance this? So overall, about 23 million patients have branch retinal vein occlusion, and about 4.7 have central retina. So the way the eye is designed is there's one entrance of an artery in and one entrance of an exit of a vein out, which is not a good design. And so what happens in these patients is that you can either get a blockage right at the optic nerve, where the blood can't leave the eye well, or you can get it downstream, which is a branch retinal vein occlusion. Yeah. And so as I said, there's two main types, branch retinal vein occlusion and a central retinal vein occlusion. And what happens here is the arteries are thick on walled vessels, and as we age, we get atherosclerosis. And sometimes, most of the time, it's associated with smoking, hypertension, high cholesterol, cardiovascular disease. And most people have, unfortunately, in the United States, most people have cardiovascular disease. And so you get this hardening, what we call hardening of the arteries. And the veins are these soft little, tubes. And so it's almost like a lead pipe on a garden hose. The lead pipe squishes the garden hose, and then the water doesn't flow out normally. And that sets up a condition where you get a thrombus, or a collection of red blood cells that stick together and block blood from leaving the eye. And again, with this, you get hemorrhages all over the retina. It almost looks like somebody threw ketchup on the retina. And edema. So a lot of again, vascular disease, a lot of these eyes end up the same way. So here's a beautiful illustration of a big, round, hard artery and squishes the little vein. And that causes the thrombus formation, and it causes hypoxia to the eye. And here's another nice picture of it. So the blood just doesn't flow right, and we end up with this turbulent blood flow and occlusion. So again, these pictures look very much like all the pictures we've seen. So this is another vascular disease, looks the same, we treat it the same, we get this edema. EYLEA is approved for the use of this disease. And here again, after we give the EYLEA, we see clearing of the edema. So another vascular disease, luckily we can use these same medications for all these diseases, So we have the same list for diabetic disease, for macular degeneration, and also for vein occlusion. And here we see this, it's a little bit dark, but there's scattered intraretinal hemorrhages and swelling. And then after the EYLEA, we see this clears. And I like to treat this disease because a lot of times we can get, especially the branch retinal veins, we can get them under control and they stay under control. The central retinal vein occlusions, you can get recurrence, and they get better, they get worse, and they're a little frustrating to treat, but they do get better, and they probably need less injections than our macular degeneration patients. So here's another example, lots and lots of edema, looks pretty bad, but after the drug it looks really returns back to normal. So with a big improvement in vision. So again, these drugs are really effective. And another picture of regression. So I just wanted to share that with you because it's another interesting disease that's not uncommon, and it may help some of you out here. But that's it.
Thank you so much, Dr. Weber. All right, welcome back, everyone. Welcome. We're going to watch a brief video from our medical director, Dr. Jeffrey Gerson. He's going to be speaking to us about dry eye disease. This is not the same as macular degeneration, so if you have questions about what is dry eye, you're about to get the answer. So he's going to go into that in much greater detail. So turn your attention to the screen, we'll watch this quick video, and we'll be able to get you that information. All right, hang on a second.
My name is Jeff Gerson, and I'm an optometrist and the medical director for the Macular Degeneration Association. I hope you're enjoying your seminar today. And I'm glad that I can present to you just a small part of it. The small part that I get to present to you today is about dry eye. What is dry eye? And we're presenting this because over the last couple of years, we've had so many questions from people just like you, asking about dry eyes or talking about their eyes watering or asking does dry have anything to do with macular degeneration. So that's why I wanted to present this to you today, and my hope is that you all learn something and enjoy it. So first, a few very basics. Number one, dry eye is not related to age-related macular degeneration. Dry eyes and dry AMD have nothing to do with each other. Now, some people with AMD have dry eyes and vice versa, but they are by no means correlated with each other. Both, as it turns out, are more common as we age. Most of the time, dry eyes can be controlled, especially with the help of your eye care provider. Sometimes people just go out and buy artificial tears and guess and happen to pick one that works well, but usually it'll do better if you consult with your eye care provider on what you can do for your dry eyes, whether it be artificial tears that are over the counter, prescription medications, hygiene, or other things. And another very basic that's really important, not all artificial tears are the same. If you go to the store to go buy some, you will literally see dozens. Some are very similar or even maybe even the same to each other, and some are very different. So there will be something that will work well or better for you and others that won't. So defining dry eye disease. Dry eye disease is a multifactorial disease, meaning there's not just one thing that causes it or that we treat to try to cure or fix it. It is unstable or deficient tear film that causes discomfort and or visual changes. It is oftentimes accompanied by ocular surface changes and inflammation. That means inflammation in your eye and changes to the surface, the front surface to your cornea. Tear film stability is usually common in dry eye disease. That means that the functioning level of the tears in your eyes are not normal. And this can be measured by your eye doctor to help define the type of dry eyes that you have. Is it a matter of not enough tears or not the right quality of tears that you have? Dry eye disease is a continuum. So it can be very mild, or in some patients it can be very severe. And this level of either mild, severe, or anything in between can be either in the signs that your eye doctor sees or the symptoms that you as a patient are experiencing. Either way, there can be a fairly broad range. Dry eye disease can be anything from slightly annoying to, in some people, it's debilitating. It can be related to different systemic conditions or medications. It can be affected by the environment. So many times people's eyes are more dry during the winter time when it's dry outside or when they're not using a humidifier. And your eye doctor may use a formal questionnaire to help define dry eye, or just ask us a couple simple questions. I simply ask my patients, are your eyes ever dry, red, or irritated? To try to help prompt to know whether you're having symptoms. What are some of the causes of dry eyes? And you can see here on the screen there are many different things, from contact lens wear to heavy reading, digital device use, people that had LASIK surgery. It can certainly be affected by diet or lack of nutrition, systemic diseases, problem with the glands that produce tears, environment. So you can see there's a whole host of different things that can cause dry eyes. So what are some of the symptoms? So probably the most common that I hear are that either someone's eyes are kind of gritty and they feel like there's something in it, or that people's eyes are watery. And I'll touch on that in a minute, why someone's eyes are watery, why that's actually dry eyes. But other symptoms you see listed here are discomfort or pain, a feeling of dryness, burning and stinging. I already mentioned the watery eyes. I already mentioned the gritty or foreign body sensation feeling in your eyes. Fluctuating vision is another very common symptom of dry eyes, especially if your vision gets blurry, you blink a couple times and it gets better. That's usually from dry eyes. Light sensitivity and redness. So these are all very common symptoms of having dry eyes. So what are some of the different tests that your doctor may do? Well, number one, they're likely to ask you questions. Some very simple, some may seem a little bit more in depth, but number one, asking questions. Your doctor will use a coloring guide, to look at the tears in your eyes, to see the quality of your tears and whether they're scratching to the surface of your eye. They may use a specific type of strip, a paper strip, to measure the amount of tears in your eyes. I know this sounds strange, but this is very commonly done in clinical trials and sometimes done just at regular doctor's visits to measure how much tearing your eyes are producing. There are devices that your doctor may use to measure the inflammation within or the thickness of your tears. And your doctor may take photos of the glands that produce different components of the tears in your eyes. So the picture on the bottom, those are two different people with a dye in their eye, and the one on the right is the one that has changes to the surface of the cornea, all the little speckles that you see, whereas on the left, in A, it's just kind of an even coloration throughout the picture. So again, B in this example is the problem. So this is showing your tear breakup time, TBUT. So normally if you blink, it should take at least 10 seconds before your tears kind of start to break up. And if you look at the image on the left here, the video on the left, every time the person blinks, if you just wait a couple seconds, you see what you have there, and the tears are breaking up. So normal tearing would be just that almost kind of yellowish-green hue over the whole surface. And I'm going to restart the video here. So on the one on the left, you see the person blinks. 1 1,000, 2 1,000, 1 1,000, 2 1,000, 3 1,000. Then 3 seconds, those tears are breaking up. So the dark spots are the tears breaking up. Normally it'd be more than 10. So if it's only 3 seconds, that means there's a problem with the quality of the tears. And therefore your eyes will end up feeling dry regardless of the amount of tears you have in your eyes. But tears aren't so simple. So what we see here is just kind of almost like a little cartoon picture, and then some facts to the right depicting our tears. Our tears have over 1,500 proteins, the natural tears in your eyes. They have growth factors, they have different types of lipids, different types of mucins. So there are literally thousands of components to your normal tears. So that's why our tears are not so simple. So let's talk about tears. So let's go back to artificial tears. So these are over-the-counter products that you buy, usually in a bottle or sometimes in individual doses, to put in your eyes to hopefully help them feel better, be less dry. And as I mentioned at the beginning, number one, artificial tears that you buy at the store, they're not all the same. Please follow the advice of your doctor on what to use. Last year, there were dozens of products pulled from the market or that received warnings from the FDA due to problems that they saw in production. There were actually some foreign companies that manufacture tears that had bacteria in them and caused big enough problems that, yes, believe it or not, there were people that died from using artificial tears after having an eye infection that spread. So really important, listen to your doctor's advice on what products to use. There are differences in preservatives. Some have no preservatives. Some have additives to make your eyes white. Some are different consistencies. Please ask your eye care provider which tears you should be using. Because if you go to look at the store, it looks like this, and it's blurry. And it is a blurry picture, but I did it on purpose, because if you go to the store, you'll see shelves and shelves, dozens and dozens of different eye drops. And can you make sense of this? Probably not. You're not trained to or educated to. You shouldn't be able to, but your doctor can. Please ask your doctor what to do about your dry eyes. I've already alluded to this a couple times, quantity versus quality. Our eyes need both enough tears, but they also need to get the right quality. So you may have plenty quantity, but poor quality. That may be why your eyes are watery. So there are specific products that help if your eyes don't have enough tears. There are specific products that help more if your tears aren't the right quality. So again, please ask your eye care provider to help you determine what's causing your dry eyes, what products you should use. Does diet and nutrition matter? You bet it does. Absolutely. So that's something that we need to pay attention to. I know it's already been talked about in diabetes and in macular degeneration, but it also plays a big part in dry eye. So mostly the same good dietary principles that apply in AMD and in diabetes also apply with dry eye. And there are supplements that you can get just for dry eye. Historically, there are fish oil based, but there are some new ones that are not fish oil based that look like they could be very, very helpful. Again, ask your eye care provider. There are different in-office procedures or things that your doctor may do to help determine or to treat. The one on the left here is using a light, a specific way to look at the glands that produce oils in your tears to see if they're healthy. On the right-hand side are two different devices that are used to heat and express oils from those glands. Both of these look maybe a little bit like torture or barbaric, but they're both quite easy to perform, and they have performed on you. But both are in-office treatments for dry eye. So don't be surprised if your doctor talks about in-office procedures that, by the way, at least as of now, are generally not covered by insurance. So there are some procedures that can be done in the office that can be tremendously helpful. Another one that can be done in the office is what are called punctal plugs. These are little plugs that are basically put in the drains that your tears drain out of. So think of the sink in your kitchen. If water's running and you want to keep the bottom of the sink with a little bit of water, but you've got the drain wide open and there's never enough water to cover the bottom of the sink, well, maybe you put the plug in the drain. And that's what we're doing here. This is a very simple in-office procedure. Generally, it is covered by insurance. They can help keep the tears in your eyes longer. This works well for people that don't have enough tears, that have a quantity problem. It doesn't work well for people that have a quality problem. That's why your doctor will need to determine what's causing the dryness. Is it quantity or quality? This may be an option. There are prescription medications for dry eye. Anything from a nose spray to multiple different prescription eye drops. And the idea of all these medications are to help your eyes produce more and better quality tears. So again, different types of eye drops, different modalities of treatment, but please do be aware there are prescription medications to help you when you have dry eyes. And they're not just to be reserved for when it's really bad. If people have tried artificial tears and they're not working or not working adequately, then we shouldn't wait before we have patients try or before you try a prescription product. Sometimes people's eyes will be very dry, and I'll talk about it. They say, well, they don't feel dry, everything feels fine. Well, that's because someone may have a problem with their corneal sensitivity. So the example I would give is, if you have a gas stove top that's on and you put your hand in it and it doesn't hurt, is that good or bad? It may be okay the first 3 or 4 seconds, but then it becomes really bad because you don't feel the pain. So some people have that problem with their corneas and their eyes can be dry without feeling it. Even if your eyes don't feel dry, they may be, and it may need to be addressed. So oftentimes it's addressed with eye drops. However, your doctor may talk to you about something called an amniotic membrane. You may have heard of placentas or amniotic tissue. So this is amniotic tissue on a little ring on the right here is what we see, that is put in your eye like a contact lens, and all the really healthy proteins and everything else within that tissue then gets into your eye and helps heal your eye and may help restore some of the sensitivity. I just bring this up because this is something that oftentimes people think sounds really odd, really weird, and I wanted you to hear about it so if your doctor brings it up to you, it's not a completely foreign or strange thought. Now, other than tears, there can be changes to your eyelid that can cause dry eyes, and so there are a number of pictures here to depict that. Sometimes we have flaky stuff along our eyelids and eyelashes, so people call it sleep in their eye. If you rub your eyes a little bit and you have all this flaky stuff, then one of these things could be the problem. It could be that the little oil glands along our eyelids are plugged up, and that's what my cursor is pointing to here. It could be something called blepharitis, which means inflammation of the eyelids and crusty debris along your eyelids that you see here. That over here on the right-hand side, you see a little bit more easily. All those little flaky, chunky things, that's not supposed to be there. And there are drugs approved to treat these different conditions. There are different causes. Oftentimes it's bacteria, but blepharitis is a word you may have heard. It means inflammation of the eyelid. Different causes, therefore different treatments, and the symptoms are oftentimes very similar and or lead to dry eyes. Usually you as a patient will refer to it as flaky or sleep in your eyes or on your eyelashes. The treatments could be anything from as simple as warm washcloth that we hold and just kind of rub a little bit to kind of clean our eyelids and eyelashes. It can be lid scrubs you may have heard of. There are different types of lid scrubs or lid wipes. There are eye drops to be used as directed by your eye care provider, over-the-counter or prescription. There's even sprays, something we spray along our eyelids and eyelashes to help with this inflammatory condition. Sometimes this inflammatory condition can be caused by bacteria, and sometimes by, believe it or not, little mites. Kind of gross, right? But as it turns out, there are prescription eye drops to take care of this. There's sprays we can use on our eyelids. There's in-office treatments. As it turns out, this is a very common and really typical condition that typical treatments usually don't work. How do you know if you have this? Your eye care provider should be able to tell you and then treat it for you appropriately. What is a stye? Well, the way I explain a stye is kind of like getting a pimple or a zit on your eyelid. Earlier I showed you the little glands along the eyelid, and a stye is basically when one of these glands gets plugged up. And the first course of treatment for a stye is heat. So really hot washcloth or one of the beaded masks generally can help treat it. Sometimes, however, we need oral antibiotics to treat a stye. What I want you to realize from this short presentation is dry disease is real and can be problematic. It can be really problematic. It can usually be managed and will be best managed with the help from your eye care professional. Not all drops, not all artificial tears are the same, so follow the directions of your doctor. Get a recommendation, a prescription from your doctor, whether it's for eye drops, a supplement that you take, like a vitamin like you would for maybe macular degeneration. But realize that dry disease is not related to macular degeneration. You may have either, neither, or both, but they're not related to each other. But dry eye disease is something that, especially if you have these symptoms, is something you should be discussing with your eye care provider, because there are some great treatments regardless of the cause. I want to thank you for spending about 17 minutes with me hearing about dry eyes. I hope you've enjoyed the program so far and enjoy the rest of the remaining to come. Thank you.
All right, so we are now going to turn our attention to the question and answer portion of the day. So if you would like, just due to the size of the amount of people here, I'm going to have a microphone set up here in the center aisle so that everyone can hear the question and everyone can get the answers. Please come to the center, and we'll have Dr. Weber up to the front now to come answer your questions. So start lining up right here, please.
Talking about the dry eye, would that be a retina doctor or a regular eye doctor?
That would be a regular eye doctor. Yes.
My other question would be, how do I follow along, like all these new medications that are coming along? How do I follow along so I know what the newest thing is? Is there like a page, is it like Facebook, Instagram, is there like someplace you can follow to see what goes on?
Yeah, I don't know if I would advise, Facebook and Instagram, because I'm not sure what you come up with and whether we'd be an expert on the disease. But you could go to like AAO.org, which is the American Academy of Ophthalmology, and they have a beautiful patient section there. And a really nice educational section. So that would be a good starting point for everything.
And we retired and moved to South Carolina, so we're getting our shots there. So does that doctor know the latest thing? Like how did they get notified as to the latest, like the HD one that's out now?
What city are you in?
Conway, South Carolina?
Yeah, certainly, if you're going to a retina specialist,
Yeah.
they will know.
Okay.
Yeah, most of the retina specialists throughout the country are extremely knowledgeable. Yeah.
Okay.
I was just in Charleston on Thursday.
What's that?
I was just in Charleston on Thursday.
All right, thank you.
Hi, Dr. Weber, how are you?
I'm good, how are you?
Good. I have a few questions. One is the Kellogg Eye Institute at Washington University in Kansas embarked on a stem cell research for AMD. Do you know anything about that?
No, but that is a very excellent eye institute. So if it's through the university and through the eye center, it's probably good.
Well, did they dispense that information to you guys, like when it comes through, if they have any conclusions?
I can certainly look it up for you.
Okay.
And see which study you're talking about. So, so I can look it up and see if you would be a candidate.
Okay, good enough. We have two patients, me and Joyce, so I'm talking for both of us. You know.
Okay.
We both don't have the exact same thing, but the other thing is there any specific treatment for GA?
Well, we talked about that in the lecture, right? So there's
Yeah.
two drugs, Syfovre, and there's also Izervay.
Well, she had the one and they took her off because it was not, she was in on 5%, I guess, or something that where it didn't work.
Oh, she developed neovascularization?
Yes. So,
Okay.
Is there anything further she can do with that?
Well, again, without knowing the patient, I'm a little hesitant to give a lot of medical information because I don't want to lead her down the wrong road. But typically, when you develop neovascularization, we put you back on, the other drugs like Vabysmo, Eylea, and get that under control, and then maybe try to introduce the Syfovre again. But again, it's something that I would have to look and see to give you the best advice.
Well, the next question would be, what do you think about a second opinion?
Sure, she can come and see me.
Yeah, I think so. All right.
Oh, all right,
Drumming up support here. And one more thing, is there any trials for GA?
Yes.
Would she be the candidate to enter them trials, do you think?
We have to see the patient because they're very specific to get into these studies.
Okay. All right.
Does she see somebody from my group that you're
She sees Dr. Mizell. I don't know what group he's
No, he's not part of my group, and I don't think he does research, so she should come to somebody in my group.
Okay.
Yeah, they're all listed here, so she doesn't have to come to me, she can, go
Yeah.
to a closer office.
Are we good, Joyce? Okay, thank you very much. Thank you,
welcome.
everybody.
Thank you for being here and providing us with this important information.
Welcome.
I also want to thank the group of doctors at the Vitro Retinal Associates in Great Neck. I started seeing them back last year. However, I wanted to ask whether a second opinion is often done in your group practices when someone is diagnosed on their first visit with
All the time, we share patients all the time. So if you wanted to see me, you could. I could give you my advice, and if I think you're getting great care where you are. I'm further out. I'm at William Floyd Parkway, so I'm exit 68 off the LAE. So, but I'm happy, we share patients all the time.
Well, that's good to know.
Yes. It's a very friendly environment.
Thank you.
Very collegiate.
But in my instance, it was that the first day I went for a battery of tests, and then the doctor examined my eye and said that he believed I had macular degeneration. And I was referred there through a local ophthalmologist who sensed that there was something that needed to be further investigated, hence and that conclusion on that first visit at the Great Neck office. What happened is that I and my wife spent a lot of time at that time there, and I was tired. So he was ready to give me an injection. And I said, I'm really tired, how about I come back another time to see you? He says, I won't be here, but another doctor can see you, and because he rotates. I said, all right. So I made an appointment for next week seeing another doctor. I investigated all of what I would anticipate in the aftermath of getting the shots and the different ways of treating myself after the injection, or what they recommended. They gave me that handout which says this is what you do when you go home after the injection.
Correct.
When I came back to the second visit, in which I had another eye exam, one eye exam, the doctor that saw me then looked at the screen and said, "You don't have macular degeneration." Well, I really was very, very shocked. Also, but they had their eyes dilated. I was in the chair waiting for the injection because they had the injection boxes on the counter. And he's saying, "You don't have macular degeneration. You have something else, but it's not macular degeneration." So, second opinion, as the gentleman mentioned earlier, I mean, it happened to me just out of serendipitous occasion. I mean, it's because I wasn't comfortable the first visit to get the injection after the bunch of tests. So my suggestion for improvement would be that rather than having the person get their injection the first visit after a battery of tests, have them come back and see another doctor and get that photograph done then before they may be getting injections, track or series of injections, and not need them.
Was the doctor who gave you the first diagnosis from the Great Neck office?
Yes, both from the Great Neck office.
And they're both DRC docs?
Absolutely.
That's a hard one to explain.
So for me, what I learned from that is that this organization and all the doctors otherwise, in addition, would, if after having all these battery of tests for the patient that day, and they make a conclusion for something that needs this kind of treatment, which is, I take it as being obviously, we know is being serious, that they hold off that day and say, come back another time, so we can just confirm what we see today.
Well, so I think, did you ultimately need injections?
No. And what I have is, since I started there, it was like spring of 23. My condition has what he says is resolved. That whatever I had dissipated, reduced in size. It went from 3 months checkup to 4 months checkup. Now he said I can come back in 6 months.
Okay, so I will say this. We do treat this disease very aggressively, because if you had come back and maybe come back 2 or 3 weeks later and the eye was worse, then we would have done you a big disservice. So I don't entirely agree with what you're saying that you should get, unless you do it in a very timely fashion. We are aggressive in the management. If we're not sure, we usually do inject, because we can follow you. We don't have to, you're not on a protocol. We need injections all the time. So sometimes we'll say, not sure, better to inject. Because if you miss your opportunity, you've really hurt the patient. Whereas if you give them an extra injection, then you say, you know what, now I see, maybe we don't need all these injections. The patient is still better off. There is risk with an injection, but there's way bigger risk than missing an opportunity.
Well, that was his comment when I asked to postpone it, and that's why I just came back a week later, which he felt was still within a reasonable time.
I think it's always good to talk to the doctor. I think 99% of the time, if we tell you you need an injection, we're on the mark. So I think you're an outlier, and I would be very hesitant to send a patient out without an injection if I thought there was a possibility that they needed it.
Well, I'm not saying that to send them out, not come back, but to come back, let's say, a week later.
You know how many patients don't come back? And then they come back and they say, now they're 2,200, and they say, I didn't understand, doctor, you didn't explain it. You know how often that happens?
I can imagine.
Very bad situation for both the patient and the doctor. So I agree with the management of the first doctor, and I'm glad you came back. I'm glad you didn't need it. Glad it worked out for you.
And it's improved, whatever the condition is.
But I would support the doctor's first decision.
All right. Thank you very much. Appreciate your time.
Sorry, I'm a germaphobe. I don't even know if that's going to help, but thank you, Dr. Weber. Amazing, just amazing. So my situation is that I'm stage 4 kidney failure person. And I was diagnosed with macular about 6-7 months ago because I had the vitreous was detaching from my retina, so that's what brought me into your practice. So then I learned, oh, you also have macular degeneration. Okay, so AREDS were prescribed for me. The problem is that I cannot handle the amount of vitamins that are in those AREDS. And so, in your experience with diabetics who often have kidney problems, because I'm not diabetic, you know, I called Preservision and I said, what research has been done for kidney patients, because chronic kidney failure and eye disease go hand in hand. Has there been any research? And they kind of fumbled around and said no. So my question to you is, in your experience with dealing with kidney patients, what other protocols are there for people like us who have limited, I cannot take a lot of, I cannot handle proteins, phosphorus, potassium, vegetables, green vegetables are very limited, very limited for me. So I'm at this conundrum where I'm desperately trying to take care of my eye health, but I'm also trying to preserve my kidneys. And I'm sorry if this is a stumper.
Yeah, so I understand what you're saying, and you know, and that's why we have to think about each patient as an individual. And there are many reasons why people can't take the, you know, the AREDS vitamins, and you're tricky because you can't really get it through your diet. I'm wondering if the Macular Health, which just has lutein and zeaxanthin, would be tolerable for you.
I was thinking the same, and I am going to ask my nephrologist.
Yeah, so, you know, they have, when you go online, I think you have to buy all their stuff online, you could do the very basic one that doesn't have, like, limited amount with just lutein. And again, you could also just take lutein separately, like a pill, and, you know, see how it goes. And if you say, I feel okay, my kidney functions are okay, then maybe add the zeaxanthin or, you know, vice versa. So you can take all these individually, and maybe, you know, get your eye health in a fashion such as that. Omega-3s are also good. I don't know if you can tolerate omega-3s.
I eat salmon once a week.
Oh, good.
Is there a blood test to evaluate the levels of these supplements?
I believe there is, and maybe you could go to a functional medical doctor who can draw those levels. They wouldn't routinely be drawn, but I think there might be a way to do that.
Thank you. One other quick question for GA. You mentioned the biologic. If I get a transplant and I am on autoimmunosuppressive drugs, are biologics no longer able to be taken by me?
No, you can take the biologics.
Okay, all right. Thank you so much once again.
Thank you for your time. We're not sure that this is the right venue for this question. Our daughter has fever, familial exuded vitreal retinopathy. They're all like one. And we were wondering if any of the things that you presented, the drugs, well, she's had the laser, but the other injections or any of the trials are a good fit for her, or are those only for
Who does she see?
Ferrone.
Ferrone is the best.
I know.
Whatever he offers you, he's one of the most knowledgeable people in the world on this disease.
Yes, I know.
So he will guide you in the right direction.
Okay, so just reach out to him and ask him about some of the...
Yeah, I'm sure he follows your daughter.
Okay.
Yes,
Thank you.
you're in good hands.
Thank you.
I have two questions. One is in regard to the dry macular degeneration. If you have that and you're taking the vitamins, is there still any reason why you should consider the medical treatments for dry macular degeneration? It's been stable.
Well, again, you know, it's always hard for me to answer these questions without knowing, you know, without seeing your pictures. And I don't want to, you know, lead you down the wrong road. But the drugs that we're talking about are for GA, geographic atrophy. And if you have no geographic atrophy, then no. you would just stick with the vitamin therapy.
And despite the lecture, the other question is this. I have wet macular degeneration in one eye, stable dry in the other, and what's not still clear to me is what the difference is between wet macular degeneration and GA. I can't, like,
Yeah, I know, it's very
Yeah,
confusing, it's very confusing. So the wet is a subdivision of macular degeneration. And basically you can go down two routes. You can go, and it's even more complicated because it can be crossover. But from macular degeneration starts as drying. Some people will go down the dry route and stay there or progress to the GA. Some people will go up down this other road, which is subretinal neovascularization, and that's wet. So you're on this road for this eye, and maybe this road or back here for that eye. And so it's complicated, and so you just need to be followed by your retina specialist.
yeah, I'm seen every 6 weeks by Dr. Graham and Rockwell said that
Dr. Graham is an excellent doctor, so you're in good hands.
I'll raise these issues with him too. Thank you.
Yes.
Hi. I was diagnosed with macular degeneration around 10 years ago, and past 2 years it seemed to be getting worse and worse. Is there anything I can do, like feel like a sitting duck, waiting for something too bad to happen, besides taking the vitamins and eating better? And also I have myopic degeneration. How does that differ from dry macular degeneration?
Myopic degeneration is a little different because that's when the retina gets thin and you can then develop subretinal neovascularization. So it's similar, it tends to occur at a younger age, and it tends to respond pretty well to our medications, like even better. So a lot of times if you get subretinal neovascularization associated with myopia, you may only need 1 or 2 injections. And then you stay stable for a while. If you have atrophy from macular degeneration, we don't have a lot of information on that, and these drugs are not approved for that use.
Would you suggest that, because it seemed to get worse the past few months and have high elevation and they suspect CNV, if I get the injection now, could that prevent it from turning red?
You have high choroidal neovascularization?
Yeah, well, they suspect it, but they're not sure. I have to be monitored every 3 months. Because I think it got a little bit better, and then it got worse, and then it's, keep going up and down. But they suspect it, but they didn't confirm it.
As soon as you have subretinal neovascularization, you need treatment.
Okay. Yeah, they just said they suspected, but they didn't confirm it.
Yeah, again, without you being my patient, it's hard for me to guide you. I don't want to put you down the wrong road. But typically, we look for little bits of blood, a little bit of thickening, and then we treat aggressively.
Could you get the injection for dry? Because so it won't turn into red? Is that a possibility?
We treat aggressively if we think that there's wet, but if it's dry, it won't prevent progression to wet. So we don't do it prophylactically, but we are aggressive in the management. So if we think it, we go with it, and then we see. So it's aggressive management, but it's not prophylactic. Doesn't prevent. Does that make sense?
Thank you.
Okay, yeah, so what he's saying is that, we want to make sure you understand that if you have dry, there's a 20% chance you're going to the wet. But that can be a little different too based on your genetic testing, so that's why we do the genetic testing. So it's not a huge number, but it's 20% about. And again, the genetic testing helps us figure that out.
Thank you for doing this event. It's been very educational for me as a spouse. I do have some questions about wet AMD. If you have, you said it could be inherited. My question is,
Yes.
if my spouse was diagnosed with wet AMD at a young age. What should we do to make sure our children don't have the same issue, or what should they be checked to make sure that they don't get,
We start screening the children when they're age 50. And what we do recommend before age 50 is no smoking, wear your sunglasses, and a healthy diet.
Okay, and I have them checked every year anyway.
Good.
Just so that I know.
And make sure they tell their eye doctor that the family has macular degeneration.
Okay, and then you said there was some home testing that may be covered through the insurance. I know that my spouse uses the grid right now. I was wondering what those other options are and how I would be able to find out they're covered through my insurance.
Yes, so the one that we really are enjoying now is a newer one called Ramoni Health. And what's really good about the Ramoni Health is you can do it on your phone or your computer. And they make it super easy, so even if you're not so, tech savvy, they send you a little email, just click on the email, you gotta do your testing, it's a 3-minute test. And the data is very, very good. Insurance pays for it, and when they notice a change, they email me. We get the patient right in, because it's always about early diagnosis. So the Ramoni is the easiest, I think. The 4C Home came before it, and it's also very good. It's a device. And like on Long Island, a lot of our patients travel, and they go to Florida, and this and that. And so to carry around like a device, they have a little suitcase. Again, carrying around a little suitcase is tricky. So the Ramoni's newer, it seems really good, and as long as you have like a smartphone or a laptop or some sort of computer, you can do it. Anyway, you can just log on.
Okay, so I'll just contact my insurance company and find out.
No, you gotta do it through your retina specialist.
Okay, and then my other question is, even if you didn't smoke, you said that smoking has something to do with it. If you lived with a smoker your whole entire life, did that?
Throw that smoker out.
But can that contribute to?
Absolutely.
It can.
Luckily our society has gotten away from smoking, and lots and lots of people have quit. So if you have a smoker in your house, they can quit, and you just gotta push them, and that's the best thing they can possibly do for their health.
Okay, and how often should you be tested with the grid on you when you have the wet AMD? Because he has one wet on one side, dry on the other.
To me, the grid, this is the grid, it's like kind of a waste of time. It's amazing somebody got this name after themselves. It's basically a piece of graph paper. So if you don't want to do the other stuff, I guess it's better than nothing, but honestly, I guess every day. How about that? Thank you.
There is also information about the 4C Home in the packet of information that you got. So there's information about the device one, not the Ramoni one, but the device one where you can sit and do the tests at home. So they have their contact information there as well.
It's a recent development. I don't know if you've heard much about it. But I just heard something recently that melatonin might be useful in preventing macular degeneration.
I haven't heard that. I think that melatonin, you
Just around June, I think.
Oh, okay. No, I haven't read that, but I think melatonin can be good for you for different reasons, and I think it is being investigated for different uses. Of course, the most common would be sleep. You make your own natural melatonin. I think there's more research going on with melatonin now, but I wouldn't advise my patients at this point. I would have to look it up and see. So if you're taking it for sleep, start with low dose, work your way up. You don't want to suppress your natural melatonin, but I don't recommend it to my patients yet. But I'll check into that. I'll check into the research.
Okay.
Hi, thank you for doing this. This is fantastic.
Thank you.
My mom is 91. She has wet AMD. So I'm concerned on 2 levels. The first question I have is, I know that you said that dry can progress to wet, but is wet always preceded by dry, or can you go straight to wet?
It is always preceded by dry, but it may not be diagnosed.
Okay.
Yes.
All right, because I'm thinking about, in her case, we didn't know she had dry, we just found out about the wet, and with the one eye, it was already too late. But in my case, I want to make sure that we're looking for, whatever we should look for, right? So if that ever happens. And that brings me to the next question, which is that there is a genetic component. How strong is that genetic component if somebody has wet AMD? Like, is it a slight chance, or should you be super careful if you have a direct relative that has wet AMD?
Well, like I said, if you have a direct relative, the relative can be tested, and we can tell you how genetic it is.
From their test? Okay.
Yes, now of course you get half your genes from your mom, half your genes from your dad.
Right.
So if both your parents have it, that's very worrisome. If only one parent has it, then it's 50-50. We don't do the genetic testing until you have drusen, because our models break down too early on. So we don't test until that point. But what I would recommend if you have a parent with this disease is that you see your ophthalmologist yearly, you wear your sunglasses, you wear your sun protection, and you don't smoke.
And that's all the case. The other question I have, and it's the last one, is about the vitamins, the AREDS vitamins, because you did mention testing to make sure that you don't have a problem with the zinc. Is that standard to do that now? Because she was recommended the vitamins and takes them, but she's 91 and her kidney function is not great, and all the other things that happen at that age. Should she be tested before she continues taking these vitamins? It's just this is the first I've ever heard of this, so.
Yeah, and not every doctor does genetic testing. It's just, some things are controversial in medicine, but I do. I think it's important, and I think the more we learn about ourselves, the better off we are. So I do it, but not everybody does it. She's been taking it for years, you said?
Yes.
She has dry?
Wet.
In both eyes?
Yes.
Stop the vitamin. You don't need it.
Oh, stop the vitamin. Oh, wow.
Yes, it's only for dry to prevent progression. And so at 90, she already gets wet, so she doesn't need it anymore. She could have stopped when she was diagnosed with wet in both eyes.
Okay. Well, that's a whole new perspective, so thank you. I appreciate it.
Yes.
Thanks so much.
Thank you. I thank you very much for doing this. First thing I'd like to say is I am seeing one of the doctors in your group, Dr. Lee, and I'll see him on Monday for my injections.
Okay.
I have the RVO. I have central in the left eye, and I have very limited. They break me 2 fingers at a foot. The right eye is 20/20, 20/25, depending on what time I go. And I'm now on a 6-week schedule. I've never gotten beyond 6. I've gone to 6.5, and I'll go to bed at night, and I wake up in the morning, and I say to my wife, I can't read the computer. I call the group, they say, come on in. So Monday, we're supposed to try that new medication, Abismo. And based on what I told you about how very frequently I have these emergency visits, even though I'm scheduled, you said something about this home testing equipment. Would that be something that I should have? Because maybe I'm not noticing the reduction in vision early enough, other than when I wake up, I really can't read my laptop.
Yeah, you could, and you'd have to use the Ramoni, but you could. But also you're being seen every 6 weeks, and you have a great doctor, and you're not going to miss too much. Like, I think, and you do the right thing, you call and say emergency, you get in. So we collect all this data, so he knows that you don't make it 7 weeks, you make it 6 weeks, whatever. So then he's saying, let's try the Vabysmo, and that's a smart thought.
Hopefully push me out a little further.
Exactly, so that's a good thought.
And I'll be honest with you, I'm totally frightened over the possibility of anything past 6 weeks. It just starts upsetting me, because I know how often it happens.
Well, you can go on the Vabysmo and do 6 weeks and know that you're probably going to be safe and do that, So come I have patients like that too. They want their injection, they want it every 6 weeks. I'm like, I think we could push you out a little more. No. So that's fine. If you want to come every 6 weeks.
No, I've tried it, but I'll get to 6.5, maybe six weeks and 2 days.
You might do better with the Vabysmo, and if that doesn't work, you might do better with the HD. I've had patients don't do so well in the Vabysmo, and we go to HD and they do better, and vice versa.
I'm doing the Eylea right now, But not
HD?
PhD, no, he didn't really want to try that. For what I didn't understand.
He knows you better than me, so I would
Yeah.
go with this suggestion.
Okay.
Yes.
Should I talk to him about this home testing?
Yes, he knows about it. He can sign you up for money.
Okay.
Mhm.
All right, thank you. Thanks again.
I'm a patient of Dr. Jonas, and about a month ago, I had bleed in my right arm. And I went 4 weeks later to have the injections put in, and day after that, I had another bleed in my arm. Now, I went back to him, and he did some tests, I'm not quite sure why, and he told me now I have dry eye. And I've been going to him for years, and all of a sudden I have the dry eye. And my problem is I can't get him to tell me technically what's wrong with me in a language that I could understand, or he's in and he's out. And I'm not sure I learned anything. So wondering if you have a list of, that I can refer to for referrals.
Well, you can, Dr. Jonas is a wonderful doctor. But if you want to come and see me, you can. But I'm at exit 68 off the LIE. And I could maybe straighten you out, and then you can go back to Dr. Jonas. He's a great doctor. I'm not saying you should leave him, but if you want to come and see me, you could. And maybe I can explain it better. I can't promise that, but you're welcome to, we share patients. And, we can work with you a little bit and get you back to Dr. Jonas, whatever you like.
I heard that he was a wonderful doctor, but his bedside manners not.
Hello there, thank you for doing this all for us. I've been treated for the dry macula for quite a while. I am on a lot of supplements for other things, and I was curious about your testing for the, I've been on ARES for quite a while. I do eat healthy greens, and my diabetes is under control, thank God. And the other thing was, I had cataracts, but they're mild to moderate. And I noticed today, thank you to you sitting next to me, they pointed out to me that there was print next to the words there, and I didn't see the print at all. And they said it was in color, and I didn't see that either. So I have color, she told me today, color distortion, and it's not because of cataracts. I guess it's because of macular degeneration. And the doctors both told me that everything goes back to macular D. That's the problem. So, I don't know what else to do. I know that, you suggested different testing, genetic testing, the OTC. Do you share the records with the other doctors that are in your group? Can you see all the records? And can you do further testing for me to see? Because walking down these stairs down here, I couldn't see the stairs. So I have very low vision, darkness. I can't plug a charger into a dark room. I can't find out. So I have low vision loss, low lighting. And I did this Samstel, whatever that called, graph. And I noticed when I closed one eye, I didn't even know how to use it. But I read that you close one eye and you look at it, and I noticed that my left eye, I can't see around the perimeter. So I think it might be progressing, and I'm scheduled to see him every 6 months. We have to come in today. I think I probably should be coming more, and I was thinking of possibly seeing.
Who's your doctor?
Right now I have Dr. Shaker.
Well, Dr. Shaker is an excellent doctor.
I know you, but the doctor referred me to him, and I like him, but I'm just wondering if there's more as far as a plan for me. Like with these extra testing.
Certainly, if you've had a change, call him up and say it's an emergency and go see him again.
Do you think I should see him again?
Yeah, I do.
Okay, sounds good. Thank you.
Thank you. Thank you, Dr. Weber, for all the information you shared. I have wet macula in both eyes. I get injections in both eyes. But when I was first diagnosed, my one eye was dry, and because treatment was delayed in my left eye, I lost central vision. So what you said about getting a shot immediately is so important, and I only wish that I did. But besides that, they advised me to take the Areds for the dry eye, and a short while later I was tested, DNA tested, and told I should not have any form of zinc. It could actually accelerate the macular degeneration. So my question is, why, when you first see the doctor, before they prescribe these Areds, why don't they suggest DNA testing?
I don't know. I don't know.
I mean, it's so simple. You know, why prescribe it if it's a risk to some people? Maybe not a lot, but to some it is.
Yeah, so there is a very complicated debate going on regarding genetic testing, and it's rather political. I'll just say that. So some people are, our academy tells us not to do that. But when I analyze the data for myself, which is something I always do, I realized that there was some underlying political issue, and the data speaks for itself. So I do it, and people are welcome to come to my practice to have it done. There's great literature, great statistical analyses from great institutions that indicate that, you know, it's very valid to do the genetic testing. That's all I'm gonna say.
I now take macular with no zinc. And
Good.
Hopefully it's helping. But I just have one more question. I do go to the HOPOG office, and my last injections, they did not use the numbing gel, only the numbing drops. I was told it was discontinued, but I have to say it was the most uncomfortable experience in the 3 years I'm getting injections. Why did they discontinue it?
I don't know. I have to tell my office. You can come to my office. It's not discontinued. I don't know.
So there's nothing you can do. You can't request it?
I don't know what they do in the HOPOG office.
They stop using it.
But you can come to my office. We have it. It's not disconnected.
So you are using it in your office?
Yes.
Well, I go to the HOPOG office. So does each office operate differently?
I guess so. I don't know.
They did not do the check. Right. September, that's when I went. Yeah, so if I insist on it, can I get it? But you don't know.
I don't know. I don't know.
Excuse me?
You may just have to
I
change
really
it.
don't know.
Thank you.
Yeah, there is a difference. I had, this is not a question, I'm going to ask about something else, but just to go on that. Where they put the gel, they antibacterial, and one time it was not washed out enough, and I wound up for a whole day with my eyes closed. I could not open them, it was like having, I couldn't even get drops or anything. It was very painful. And now I always request, flood me, wash my eyes out before I leave, and we're okay now. My question is regarding supplements. I've been on supplements for years. One of them is lutein, one is acid, I can't pronounce it, and there's Sight Care, which I received online, which supposedly addresses all of this, along with other multivitamins. The question is there a problem or can you have too much strength? Like my lutein, my Sept lutein is 20 milligrams. Is that too much? Should I get something that's less? I saw you had 10 milligrams.
20 is fine. 20 is good.
Okay, so there wouldn't be any problem or any adverse reaction if you have, because as I said, I'm taking a multivitamin, and there is a very small amount of lutein in that, and there's the zinc, all those things that are in there. So that's why I don't get Dr. Shakin once said to me, you want to take the, I don't know if it wasn't Prevagen, one of the ones that they recommend that are specific, or occupy whatever was there. And because I took everything else, didn't need it. So they say, is there that problem of over supply?
I think there is. So like if you take the Ocuvite and a multivitamin, you're getting an awful lot of like C and E, and which could, C is not too bad, unless you have kidney disease, but E, you might get some bleeding problems, so I think you can overdose,
Well, I'm taking the Ocuvite, that's why I'm not, because I was taking all these others, so I said you don't need
Yeah, so if you're taking a multivitamin, you could just get away with lutein and zeaxanthin.
Okay.
Yeah.
So we're still good then? Okay.
Yeah.
Thank you.
Sorry, I'm going to ask a similar question. This vitamin thing is confusing. I have wet in one eye, dry in another eye, and I have low pressure glaucoma, severe. I've been on AREDS for probably 15 years. And no one has ever mentioned anything about not taking a multi or continuing with the AREDS. I'm scared to heck.
Right, so again, I do the AMD genetic testing to figure out, which vitamin you should be on and whether you need zinc or not zinc. So that's what I do, and then, the other part of your question was?
No, just, that really answers it. I'm coming for genetic testing. Thanks.
Okay.
Thank you. I'm here really for my mother. She's in her mid-80s. She has geographic atrophy, which from the appointments that I've been to with her, they say, oh, it's really bad, it's really bad. So, but nobody really has mentioned about doing the injections. So I'm wondering, when is it not worth even trying?
Yeah, it's interesting because I had a discussion with someone just now in the hall, and I think it's a very personal decision. So we do offer it to everyone, and if you have GA in both eyes, we usually say, let's do the better eye, and try to save the better eye. But I have patients who want it in both eyes, even if one eye is pretty low. So insurance will pay for everything, so you don't have to worry about that. And then it just becomes a very personal decision, like can you make monthly, you really should get it monthly, can you make monthly appointments? If you can make monthly appointments, are you okay doing both eyes at the same time? If you're not willing to do that, then you're really spending an awful lot of time in our office, which, again, you don't want to spend your life in the doctor's office. You want to go out and have some fun. So, there's a lot of ways of looking at it. We talk to the patients, we try to figure out what would be best for their visual needs, and take it from there.
She's also like mid-80s, but has had some issues with anxiety and a little bit of Alzheimer's. So she's kind of freaked out about the shots. But I told her, if you got through the cataract surgery, you should be able to do the shots, right? Isn't it an easier procedure?
Oh, yes, way easier.
Okay.
Not even a comparison.
Because you're telling her that. Okay. And so one of the things, she's been going to the doctor every year for like 20 years, been taking Preservision, and I don't know why, it's just in the last few years, all of a sudden this cropped up. You got the AMD, first it started with dry, and then it's wet, and now it's geographic atrophy. And it seemed to happen so fast. I don't know, my dad dying maybe, stress progressed it. Does that happen?
No.
Okay, it's
I
just
wouldn't worry about that.
with the eyes. So now in your practice for her situation, it seems like it's advanced geographic atrophy. They tell me she lost her sense. She doesn't have central vision. So do you have somebody that you would think would be the best doctor in your group? I think she's gone to the Comac office just once, and they really didn't say much about helping her. But her regular doctor, like the ophthalmologist, all of a sudden says, oh, I can do shots now. So I don't know if we should be having her do shots, or, you know, I was thinking if we do shots, maybe go to your place, because I don't know, the other doctor has done cataract surgeries, but didn't want to do my mom's because it seemed to be too far gone. So now I'm kind of afraid of letting her do shots. I don't know. What do you recommend?
Who's your doctor?
I think she saw a Dr. Shaking, but only once at your office in Comac.
Okay.
Prior to that, she was going to Mount Sinai doctors, probably for at least 20 years.
Okay. Yeah, unfortunately, we closed that office, unfortunately.
Oh, the Comac?
Yeah, but you could see Dr. Shakin in Hop.
Yeah, I was gonna say, it's been at least over a year.
Yeah.
Was it a year ago? You guys were still open?
Yes, we were.
Yeah, I think it's been about a year. Because it was after her cataract surgery that we were trying to find a retina specialist.
Yeah, so, you know, again, Dr. Shakin can help you. He's great. Make an appointment to see him.
Okay.
Yeah, he's great.
Okay, thank you.
Okay, this is going to be the last question. We got to get wrapped up.
Hi, again, thank you for doing this. My question is twofold. It's about two different people. And one person that has one dry eye and one wet. The dry eye is not being treated at all. It's being monitored. The wet eye is getting injections. Is that a normal thing? Because I know you said that you treat aggressively. So should something be being done with the dry eye?
Again, you know, without seeing the patient, it's hard for me to know, but if there's no GA, then we would not be treating.
Okay, so that's not a problem. And the second question, my mom has dry MAC in both eyes. She's had it for, I'm going to say, 30 years at this point. She's lost her central vision, and she has no treatment whatsoever. Her doctor, her regular eye doctor, the last time she saw him last year, told her she will not lose her vision permanently. I didn't get that from you today. I got the impression that she could, in fact, go permanently blind. Did I get the right information? Because I'm wondering if this doctor, he's a good doctor, I know he's a good doctor, his name is John Romanelli, but I'm wondering if he told her that because she was panicking and she's afraid of going blind. So he said, don't worry, it's not, he said, it's not going to get any worse.
You know, I would take her to one of the retina specialists. Dr. Romanelli is a great doctor, but he's not a retina person. So just have a retina person verify.
Okay.
He's probably telling you the right thing, but again, without looking at records and studies and everything else, it's hard for me to advise. So it's always safest to see the retina specialist, you know, and get their blessing and then go back to Dr. Romanelli.
And do they do the DNA testing in the hospital?
No.
They don't, only in your office?
Yes.
Okay, and that office is where?
Shirley, exit 68 off the LIE.
Shirley, and it's called LIER, what is it called?
Yeah, we're part of Vitro, it's VRC, they call it VRC. We have the address here if you.
Yes, I would like that.
Sure.
Thank you.
Yes. No.
All right.
That's my knowledge.
So one last question that, since you touched on this, Doctor, if you want to give them the information, is if people are interested in participating in clinical trials, and they're not necessarily in this area or they are in this area, what is the best resource to find out what clinical trials are in their area?
So there is a website, clinicaltrials.gov, and it's pretty easy to use that website. You can put in the disease you want, the area you want, and it'll come up with the research studies that are valid, you know, that you want to be involved with. Yeah, clinicaltrials.gov. Yeah, that is correct. You have to look at each trial, and there's inclusions, exclusions, all this stuff. So it's sometimes hard to get into the study, and they're very specific because they want to be studying a particular type of patient. You're not going
All right, we want to thank you so much for attending today. If you do have any further questions, you can come up and talk to the doctor, but unfortunately the program is over, so I have to pack up the equipment. So thank you so much for attending.